and the heart rhythm looks like the waveform from a Ramones guitar riff. Let's get into it. What's up everyone, Mike Muellner here. I'm an internal medicine doctor from Los Angeles, California, and today we're going to talk about atrial fibrillation, otherwise known as Afib. So this is a very common arrhythmia that I see in the hospital all the time. Probably not a week goes by that I don't see this rhythm at least a couple times. And what happens in this is you have the small part of the heart which ends up fibrillating or vibrating very quickly. And so this is an arrhythmia, it's an abnormal heart rhythm. And just the small part of the heart vibrating might not be such a big deal, but the problem is that some of those impulses get transmitted to the ventricle or the larger part of the heart, and this causes what we call atrial fibrillation with rapid ventricular response, or AFib with RVR. And so this is a big issue. In this case, the heart rate can be as fast as 130s, 140s, even 150s, and when people experience this, it's very disconcerting. They feel their heart fluttering, palpitations. It even compromises the blood flow through the body, so the brain doesn't get enough blood. Then you feel lightheaded or dizzy. You can even pass out. And so it really makes the heart pump very inefficiently. And so because of this, one of the mainstays of treatment for atrial fibrillation is heart rate control. Now, back in the day, the thought was maybe we could cardiovert or get out of this abnormal rhythm. Maybe that would be a more effective strategy for treatment. But there's been studies that have shown that rate control is just as good as rhythm control. And it's a little bit easier to do, and you don't run the risk of having the abnormal rhythm come back in the future. So to establish rate control, there are several medications we use. One common one is a class of medications called beta blockers. So these are medications including metoprolol, bisoprolol, carvedilol. They help to slow the heart rate down by blocking beta adrenergic receptors, which decreases both contractility or the force that the heart pumps at and also heart rate. Another common class of medications that's used to control heart rate is calcium channel blockers, but specifically the dihydropyridine calcium channel blockers. So these are medications like diltiazem or verapamil. They also help to control heart rate. Now, the side effect of calcium channel blockers and beta blockers, or at least one concerning side effect, is that they can drop blood pressure. And commonly when people have atrial fibrillation, especially if it's in a rapid ventricular rate, they can also have very low blood pressure. Now, paradoxically, when you control the heart rate, sometimes the blood pressure does go up because the heart's pumping more efficiently. But still, you don't want to give any medications that are going to really drop the blood pressure. And technically, both calcium channel blockers and beta blockers are antihypertensive medications, or medications used to treat high blood pressure. So if the blood pressure is low and you have rapid AFib, what do? Well, one medication we can use is Digoxin. And so this is an old school heart medication. And the problem with this one is that it has a very narrow therapeutic window. So it's hard to get the dosing just right. You actually have to check levels of the drug. And it's quite easy to end up having too much of the drug build up in the body, and then you get digoxin toxicity. Or conversely, you can have too little of the drug and then it's not effective. So because of this, it's a medication we like to avoid if at all possible for treatment of rate control. We would much prefer to use a beta blocker or a calcium channel blocker. But with that said, the good thing about digoxin is it doesn't really affect blood pressure too much. So in people who have lower blood pressures, but they have rapid AFib and you still want to control the heart rate, digoxin is a medication that can be used. It can be used in both an IV form and also a pill form. So that's rate control. But what about rhythm control? Are there ever instances when we want to just break this atrial fibrillation rhythm altogether and try to convert back to a normal sinus rhythm? And yes, there are certainly situations where that is the case. One situation would be in hemodynamic instability. So if the heart rate's just going out of control and the blood pressure is tanking and the patient's quite unstable, maybe they're even becoming lethargic or unresponsive, there you don't want to mess around with rate control medications. Unfortunately, that would necessitate shocking the heart to emergently get out of this abnormal rhythm. All right, so that's a quick introduction into rate control for atrial fibrillation, but that's not the end of the story. There's also another big concern, and that is that the vibrating or the fibrillating part of the heart, the atria, in the case of atrial fibrillation, it causes blood to pool. Then blood is much more likely to form clots. These blood clots can then go to the brain and cause a stroke. That's right, atrial fibrillation dramatically increases risk of having a stroke. So what do you do about this? Well, doctors will calculate a score called the 𝐂𝐎𝐍𝐍𝐄𝐓 score. It looks at other comorbidities like congestive heart failure, diabetes, history of stroke in the past, and based on that, doctors can calculate a score which helps to quantify the risk of having a stroke in the future when you have this abnormal heart rhythm. And in many cases, I mean, these things are common, right? A lot of people have diabetes. A lot of people have congestive heart failure too. So it's not at all uncommon to have a 𝐂𝐎𝐍𝐶 score of 2 or greater, in which case it is recommended to take anticoagulation as long as there's not other risks of anticoagulation, such as bleeding. You certainly wouldn't want to give anticoagulation or a blood thinner to somebody who's having a brain bleed, for example. But in the absence of contraindications, anticoagulation can really go a long way to prevent stroke. So how do we do that? How do we establish anticoagulation? Well, the mainstay is blood thinner medication. So classically, what we would use back in the day when I was in school, I mean, now I feel so old, this was about 10 years ago, the only oral anticoagulation we had was warfarin. And so that was the medication we would use. And warfarin's very old school medication. The problem with it is that, sort of similar to Digoxin, you do have to monitor levels. And so patients who get started on warfarin, they end up having to get their INR drawn. That's a blood test to help check for how thin the blood is as a result of warfarin. And so that's pretty inconvenient. And so because of that, now we have modern, newer blood thinning medications like dabigatran, apixaban. These are much easier to use because you don't have to check levels. You don't have to come in for a blood test. So these are the favored oral anticoagulants. There's other ways to make the blood thin. One of them is Lovenox or enoxaparin. These are subcutaneous shots. And so the benefit of this is that it doesn't last long. The effect is quite transient. And so in people who are in the hospital, maybe they're getting ready to have a procedure, a surgery in the future, and you don't want to wait several days for the effect of warfarin to wear off, you can switch to Lovenox shots and then stop those before the surgery for a quicker reversal. So how do we diagnose atrial fibrillation? Well, it's one of the EKG findings that's very classic, one that all medical students learn, and that is this, what we call a narrow complex, irregularly irregular rhythm. So it's narrow complex in that the spikes, the QRS complexes, they're not wide, they're narrow, they're very skinny. So it kind of looks like sinus rhythm, actually, in that sense, because you have narrow QRSs. But unlike a normal rhythm, there's no P wave. So the P wave is that little blip that happens right before the QRS complex. And in atrial fibrillation, the atria, where you would normally get the P wave coming from, it's fibrillating. So you don't see that on the EKG. Instead, what you see is just irregularly irregular QRS complexes. And so for this, you can see that quite clearly here. The spikes on the EKG are happening very irregularly. It's not a steady beat. It's kind of all over the place. And so those are the classic findings on EKG for atrial fibrillation. Okay, thanks for checking out this video. I hope this was a helpful introduction into atrial fibrillation and some of the issues that can arise as a result of this abnormal heart rhythm. If you like medical content like this, feel free to check out another video right there. Also, if you feel so inclined, here's the subscribe button, and also smash that notifications or whatever it is YouTubers say. But anything you guys do really would help out the channel a lot. So I really appreciate it. And until next time, I'll see you guys later.